A year ago, I was finishing my second to last semester in nursing school, and now I'm 2 months off of orientation. I work for an emergency department in a city hospital, and I have finished. I've done 5 months of orientation. I think 5 weeks that was didactic, so think of it as like a continuation of nursing school. And then 4 months of clinical immersion where you're on the floor, you're learning how to be a real nurse. The first month is shadowing. And then I spent 3 months with a preceptor. So from New Year's up until March 21st, had a preceptor hold my hand, teach me the ropes, teach me the needles, the medications, the orders, the way how the ED flows. And now I've done a month off of orientation where I've been by myself figuring this shit out, still learning how to prioritize, how to manage time, pain management, how to manage expectations in patients. I think that is one of the biggest things that you do not get taught in nursing school is the person, the patient that you're taking care of. Aside of the illness that they're having, it's what's their temperament like. And it's a lot. It's a lot, but it's also I love it. I couldn't see myself doing anything else. And yeah, so every day is a shit show and it doesn't get better. You get better at dealing with the bullshit, navigating the bullshit. So, I've compiled a list of notable things that has happened in my first month off of orientation. So, March 25th. You know what? We're not going to do any days. We're just going to say my first shift off orientation, I was a swinger. The fuck does that mean? So, you have two teams in my emergency department, team one, team two. So you have patients that are going to be with team one providers and team two providers. Trying to figure out how to be a finger, try to finger, trying to figure out how to be an effective swinger at the hospital is tough because you have to room patients in the right place. And let's say you run out of rooms, now you have to put them in the hallway, but they also have to be on the right side of the hallway. The first difficult patient that I had wasn't even my patient. It was my coworker's patient. And this lady is, you get these patients that think the ED means it is their special place, they're a special person, all their needs, their wants has to be attended to immediately. And this lady was upset at the time that it takes for things to get done. And not even things to get done, for results to show up. I do not have any control of how long it takes for the lab upstairs to go through blood to analyze it, or the imaging results that come from CAT scans, from the x-rays. I'm not in control of that. So you have to learn how to manage expectations. And it makes sense because if I come to the ED, I want to know what the fuck is going on, da 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 da, which means you need a nurse who understands the flow of things, who understands how to interpret results, who is good at communicating with providers and going back and forth so that you can give the patient the knowledge that they need so that they can calm down and be patient. So this lady was not patient at all, and I'm trying to be very, very nice and very patient with her. And she gets to a point where she becomes admitted. And the thing that sucks, because I've seen this also in shows like The Pit, you call them boarding, where we had these patients stuck in the emergency department because we don't have room upstairs. And it sucks. I understand how frustrating it must be to just wait to be transported to a different place so you can receive better care. But honestly, I don't want to say better care, just more specialized care. Because if I am in the ED and I'm dealing with patients who have acute problems, right? Things that need to be fixed right now. But then I'm also taking care of patients that are going to have a longer stay, which means they need different type of treatment. They need different type of monitoring. It's too much to juggle to handle somebody who needs a lot of time, attention, and care, and somebody who needs quick time, attention, and care. So I was managing 6 to 7 all day until my coworker took a break, and then I had 13. Oh, go back to that lady. The lady got so upset. She's calling people, right? She's FaceTiming people, and then she's recording. She's FaceTiming people because she doesn't understand. She just doesn't know how to be patient. And then she's recording my coworkers saying, "Look at these people not doing shit," and then going into patients' rooms, right? Disrupting privacy, talking about, look at these patients not receiving care and da 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 da. And it's just like, you can't do that, one. And then two, when I'm trying to come up to her and explain all this stuff, then she has a phone. She has the phone like right in front of my face. Look at this nigga not doing da 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 da. Oh my god. So then she calls me a whole bunch of names, and I'm very calm because I'm giving the opposite energy. If she's high, I'm low because I'm trying to bring her back down. So anyway, she got admitted upstairs and then was escorted out because I don't even know why. It's just if some people want to be miserable, so they stay miserable, and there's nothing that I can do to change that. Then I don't like ICU nurses, so when I'm juggling with so many patients in general, and then some of them are admitted, and then it's towards the end of a shift, so I'm just getting new patients. Like, it's hard for me to document everything properly on a patient. So the process is we have to call to give report, and if somebody doesn't give report, then we have to write down a report on a paper that gets sent up with transportation, and it basically outlines what's going on, right? What's going on with the patient, why they're here, why they're being sent up, da-da-da-da. It's like the most important things. But then, again, I don't have time. And when I don't have time, other nurses don't have time, so we can't help each other out. And I called, the issue that I have with the ICU nurses is like, when I brought my patient upstairs who was unstable, I wrote something in like, it took me 30 seconds to write down a few things, but it wasn't the full report because I was waiting to give report to a person who never picked up the phone. And I called this unit twice. So I get up there and I'm just getting looked down upon like I'm an inadequate or incompetent nurse. Like I don't know what I'm doing. How did the patient arrive here? Arrived on a fucking magic carpet. Does it matter? It's not going to change how you treat this person. If they came by EMS, if they walked in, the patient is here, figure this shit out. I'm a type of person, type of nurse, type B nurse. Give me as little as possible. Just tell me what's important right now. And then I'm going to use my eyeballs to read the chart and understand things. Because here's the thing, right? What the patient tells me might be different than what the patient tells you. What you have documented might not be what I'm seeing in person. So fuck out my way. Let me figure this out. And then you have the nurses, and this guy was trying to be like I said, trying to make me feel small. And when I told him that I called, and he was like, well, I've been here, and da-da-da-da. And then he looked at the paper that I wrote, like, yo, what kind of report is this? I'm like, yo, I called. Are you calling me a liar? And I had to say this in front of everybody there because he was trying to make me feel small. And once I'm like, you stand up to these bullies, these bullying nurses, they back down and everything is calm because now they realize they can't just walk all over you or talk to you crazy. So me raising my voice, are you calling me a liar? Are you telling me that I didn't call your unit twice and nobody picked up the phone? I'm just here. I'm up here for fun. So these nurses will also have the multiple nurses taking care of one patient. Meanwhile, I'm one nurse taking care of multiple patients, and I'm trying to figure it out. So when you have these things to say about how ED nurses don't do X, Y, and Z, we don't have the time, we don't have the resources. You do. Figure this shit out. Also, I had no breaks that day, and that was my day one. Second day, 8 patients, 4 admits. 3 people got a bed at the same time, which is nerve-wracking because I didn't take the time to write down a report or anything. So luckily, my coworker, Marissa, was able to help me handle that while I'm handling the new patients that are coming in. And within like 30 minutes into my shift, as I'm getting blood from a patient in his room, a random person walks into the room, pulls his dick out, and then pees in the sink. The fuck is going on? Oh, sorry, bro. I couldn't wait. I couldn't hold it any longer. We have urinals. We also have bathrooms. The fact that you couldn't wait is not an excuse. But now I'm trying to explain to my patient what's going on and telling them like, yo, I'm sorry for all of this shit. Then I have to call EVS so that we can get this immediately cleaned because of the smell of somebody who is not taking care of themselves and then pees inside of a sink that's like, oh my God. My third shift, I was in fast track. I think because of how crazy my first 2 days were. So as somebody who works in fast track, I have time. I can go out to the teams and help, go to trauma and help. You know what kind of help I did when I went out to teams? Nothing. I just made it harder for the nurse that was taking care of these patients, missing every single fucking line. But the only highlight for my third day off of orientation was that I got a Foley into a woman with the help of my friend Aaron. And yeah, that was the first time I did it, and it was in a trauma setting where you had to do a quick da 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 da. And yeah, I got a Foley into a woman. What's funny is that what I thought was the urethra was a clit. And there's a lot of not a lot. There's some things in nursing where it's a two-person job. So luckily, I have somebody who's spreading legs, who's bending knees, and then adjusting the lower half of someone so that it makes it easier for me to visualize visualize everything. So my fourth day, I had 10 patients all day. 5 to 6 of them were admits. One of them was a trach patient with an NG tube who was non-verbal, non-anything. And so taking care of this person was scary because you have a lot of drips. You have a lot of body mass index. You have things to take care of. The other thing, too, is like this person came from a home. And now I know in the back of my head, when I hear home, I need to think pressure ulcers. I need to do full skin checks because it's so sad what happens to these patients when they're living in homes that they don't get the time and attention that they need, the care that they don't get. And so you develop an ulcer in your skin breaks down because you haven't moved it for so long. That is the saddest fucking thing. Anyway, this was also a day where we had no PCAs past noon because it was, I think, Eid, and I was missing every fucking line. And one of my patients shit on himself twice, but I was told that this person is agitative, aggressive, and threw their pee at the night nurse before me. So I was expecting the worst. The only thing we had to do was just clean them up twice, which was fine. And I'm the type of person where, like, if I ask a PCA to do something, I'm also going to offer help because, again, two-person job, it's so much faster, so much easier. One of the weirdest things that happened to me was I had a patient who came in with her 2 sisters, I think, 2 family members, and her niece. And I'm taking care of them. I'm really good at building rapport. So at the end of their stay, everything is good. I'm bringing the discharge papers. I'm taking out the line. One of the ladies, or one of the friends of the patient, is saying, "Hey, I got pizza. Do you want some?" And I was like, "Nah, sorry, I can't have it." And she's like, "No, it's okay. Like, we have extra. It's all good." And I was like, "No, because I have a food allergy, right? Unless this pizza is gluten-free, I can't have it or else I'm going to experience problems." And then her first thought, said this in front of everyone, including the child, was, "Oh, that must mean you got really good dick if you have a food allergy." What? How do you make that connection? I'm used to getting flirted with at work. I'm used to getting hit on. And I'm not saying that as like, "Oh, look at me." I'm just like, it's just a thing that happens at my job. But for someone to say that in front of a small person, a child, inappropriate is an understatement. 5th shift, I'm working in trauma. Drop my coffee 4 minutes into huddle. It's not going to be a good day. But I'm lying because everything was good after that. Then I got an 18 gauge into a patient very quickly. And also, I now know when you hear a vibration, right, when the catheter is inside of a vein, that's because you're in a valve. Oops, didn't know that. That's what that shit means. So I learned that. Had an agitated man that wanted to fight me when he came off of cocaine. And again, I don't know what it is to take cocaine or wake up from taking cocaine, but this man was upset, wanted to fight everyone, didn't know where he was, and was peeing crazy. I straight cath a man. And it's so much easier to put a Foley or straight cath a man than it is a woman, right? There's one hole. If there's uncircumcised, peel that shit back and then put it in. It's so much easier on a man than a woman. And then also here at my 5th shift where I saw a patient that came in through trauma had the worst ulcers I've ever seen. This is past stage 3 and stage 4. It's unstageable and with tunneling. So yeah, when a patient is coming from a nursing home, pressure ulcers, they're going to exist. Okay, so my 6th shift off of orientation. Well, within 15-20 minutes, I have a patient that needs to be discharged. He came in for chest pain, got diagnosed with alcohol intox. Cool. So as I'm trying to, this patient is also in the hallway. As I'm trying to explain to this patient that he's being discharged for X, Y, and Z, he's asking for a room so he can change. All right, cool. So I put him in a room, and then, I come back in. I give him 5 minutes to change, and then I'll come back. When I come back, this man is only wearing a wife beater. And how do I know this? Is because when I'm looking at him, eyes to eyes, Then I can see peripheral vision. I see a head that's just moving. This man has his dick out underneath the sheets and again locking eyes with me and playing with it. I take a step back because now I need to create distance. So I'm explaining to him that he needs to go. He's telling me he doesn't have a way to get home. He needs a cab or a Metro card. Cool. So we'll figure that out with social work. Put your clothes on. I'll be right back. I come with the social worker. He's fully clothed. Everything is good. We have a cab that we're going to call. Sir, you need to get changed quickly. Cool. I come back in 5 minutes. Mans is naked. He is standing up. He's in a room with another patient and there's a curtain dividing everything. So when I get in there, I'm just like, sir, the cab is on its way. You need to be outside within the next 5 minutes. If the cab comes and you're not there and they leave, it's on you. Cool. I come back in a couple minutes. He is in bed. He's in bed. He hasn't put on anything. And again, playing with his dick. And then I create distance. And as I leave, because I'm telling him, I'm going to come in one more time. And if you're not here, I'm going to have to get hospital police to help me escort you out. He tries to grab my hand. So I'm assuming, right? Grab my hand so I could touch his dick. This is unsafe for me. This is inappropriate. I'm uncomfortable. Bye. So yeah, then when he left, the other nurse was telling me how they saw him masturbating behind the cover. And then later in the day, when I talked to the other patient, he was shook and telling me how the guy was not only masturbating, but peeking through the curtain so he could make eye contact while he's playing with himself. What the fuck is going on? Later that day, I had a mom who came in with her son, who was a patient, and I'm talking to her and him. Everything's good. I gotta go get meds for another patient. When I come outside into the hallway and I'm about to pass in their room, mom is passed out on the floor. Help! I'm yelling for help, so other people come, and then we assess this woman. She's basically dehydrated, and I think because of her son being like special needs, she hasn't had the time to take care of herself, to rest properly. So she got triaged. She became my next patient. Gave her, I think, Tylenol, gave her fluids, and she was okay. She just needed a break. I had a patient later in the day. Rip out his IV after I told him that he was being discharged and I had to go get the stuff so we could take it out, blah, blah, blah. When I come back, I'm looking for the IV that I placed. It's no longer there. I'm like, where is it? He points to the counter because he took everything out and put it in a basin. Somebody else's shit was in there and then he just did that. And I'm like, yo, you can't do that. I was like, what about bleeding? What about infection? Da-da-da. He's like, yo, I seen this shit on TV. I know what to do. And the body fights off infection naturally, so I'm good. You're not good because you're in the ED. What are you doing? So I try to explain you can't do that because X, Y, and Z. He doesn't care. It is what it is. He leaves. But that was just insane to me. That day, 11 patients at my most with 7 admits. What are we doing? 7th shift off of orientation. I sometimes, if my laundry isn't done, I'm going to wear a shirt that has the same colors for work, like dark blue, light blue, whatever. And so when I wore this t-shirt, it was a little bit tight, admittedly, which female patients love. And I had one guy at the end of the day who came in for alcohol intox and didn't really get any type of treatment. He was just there to sober up. And then while he's leaving, he was like, yo, shirt's too tight, bro. And then left. Here's this thing too, right? It's happened to me multiple times. It's impossible. I'm not a babysitter, and I hate it because it makes me feel like shit when I have a patient who just leaves even before against medical advice, right? Because against medical advice means I have time to tell you how stupid it is for you to leave because you could get seriously hurt. Your condition can become worse. You can deteriorate, and if you're not here while we're taking care of you, you can go out there and die. Left during evaluation. I've had a few patients. Like when I'm having double-digit patients, it's hard for me to keep track of everybody because if they're not there physically where I left them, either they're in the bathroom, they're doing imaging. And so I just assume, okay, cool. Now when it's like an hour or 2 hours and I don't see this person, now I have to figure out where this person is. And I hate it so much. So yeah, and that whole stretch since I've came off of orientation, I've had a few patients leave, which I hear is fine. It happens. You can't control it. The only thing you try to do is make sure that they don't have a line in because then if they're a drug user, you're giving them easy access. I also dealt with a patient who was a burn victim, and half of his face was gone. And it is one of those things you see, and it makes you appreciate your life and how healthy you are, because it can always be worse. Seventh day off orientation, I had a patient who came in for constipation, hadn't moved his bowels in a few days. And when I told him about Miralax, he was like, nah, I need something stronger. What's the stuff that they give you for a colonoscopy? I want that. And I'm like, cool, let me go talk to the doctor and see if we can do that. So then he asked me, yeah, and when you get it, can I just take it home? And I'm like, you can't do that, which already should have been a trigger, like this man is going to leave. So we ordered Go Light, which is something that comes like, it looks like a gallon of gas. That's the container, but it's powder, and then you just gotta fill it up like all the way up, shake that bitch, and then give it to the person and enjoy. And once you are drinking this and you finish it, by the time you're done, you are going to be shitting your brains out. So I gave him the Go Light, and then I didn't see him after that. The man left. He went home to shit in peace. Eighth shift off of orientation. I went into trauma to try and help because I heard an overhead page, and by the time I got there, the lady was gone, and her daughter came in to visit. And when we let the daughter go in to see her mom, it is a sound, when they cry, that I can never forget or get out of my head, because it's the same sound that I heard when my mom was crying for my dad as we lowered the casket. And that's one of the few times, like in the ED, where I was just like, bro, this is a lot right now. I've been involved in a few codes. I've seen a few people die. It's easier now to compartmentalize that, but just hearing that sound of a woman crying for their loved one, it's something you'll never get out of your head. Later that day, I'm proud of myself. I got a Foley into a woman for the first time by myself without any guidance. I had a nursing student help me in terms of like positioning and cleaning. I'll get to the cleaning part. This lady came from a nursing home, urinary retention. Her stomach is distended. Cool. We need to get this Foley inside of this woman ASAP. Remind you, I've never done this before by myself, so I'm trying to figure this out. I try to go to Aaron to try, or I think Bunch, to try and help me, be the guide or whatever. And they're like, nah, you got it. You need to learn how to do it. So I went in there. My tell is easy. I have a poker face until I am overwhelmed or stressed in the moment. And you can tell because sweat is dripping down my forehead and I can't control it. So while we undress this woman, I'm getting everything set up. And as I spread as much as I could with this lady, there is shit underneath her. So now I'm worried not only about like the bladder that's distended, that I need to get a Foley inside. Now I'm thinking about smell and a possible UTI, some type of infection, because she's laying in like a small puddle of her shit, which is like creeping up to her vagina. I'm trying to spread as much as I can. I only see clit. And while I'm trying to figure out how low do I need to go, because once I put the Foley in, I can't let it touch the shit or else we have bigger problems. And then she's also, I don't say moaning, groaning. So that's also building up the intensity of what's going on, right? I'm getting overwhelmed and becoming stressed because this woman is groaning in my ear, very, very loud. The nursing student who's helping me is looking to me like, yo, I don't know what to do. I believe in you. You got this, bro. The home aide is looking at me like, is he going to get it? And I'm over here sweating bullets like, fuck. What do I do? So I spread as much as I can. I'm assessing. I'm hearing this. And then I'm like, I'm just going to go for it. This is a half court. This is a full court fucking shot with my eyes closed. Now I go in. And then I'm getting to the end of the tube and I'm seeing nothing until I get to the end. And then we have urine coming out. Thank God. Oh my God. So luckily I didn't go into the vaginal canal. And I got it into the urethra. So I still don't know what I did, but I did it right. She was able to pee. We got samples. Then we turned her over to clean her up. And this is where things get interesting. She's 61 years old. And now once her bladder is no longer distended, she's got all the urine outside of her. We gave her medication. Now she can think. And what is the first thing that she says as I'm giving her medication and explaining to her the next steps? Whew. boy, you are jacked. I've never met a jack nurse like you before. And I'm like, cool, thank you. And then she's like, and isn't he gorgeous too? And she keeps on going for over a minute. And at one point, I'm not uncomfortable, but I'm like, I just want to make sure, we're on the same page. Are you flirting with me? She's like, oh, I'm sorry. I don't mean to make my doctors or my nurses feel uncomfortable. It's just look at you. And I was like, I appreciate that. And then I slid her up in higher into the bed by myself, and she goes, oh, and strong too. I see where those muscles come from. And I was like, thanks, I tried. She's like, baby, you ain't trying, you doing. And I was like, ugh, okay, cool. I appreciate that. Now, the medications are given. We're doing this. I just got to wait for imaging, so I'll be back in a little bit. Do you need anything in the meantime? Cool. It was funny. As soon as she was fine and no longer in pain, flirt. My ninth shift off orientation. I had a MRSA patient with MRSA infection, come out of his room, pull out his IV after I gave him food that he requested for because he couldn't wait any longer for a bed upstairs. And I'm trying to figure this shit out while this man is in the hallway sitting down on the floor, and I'm just like, bro, like infection, contact, get out, it's a lot. There are things that happen in a split second where you're just like, I have to figure out what to do, and I've never been in this situation before. I was able to calm him down, but he still ripped out his IV, so I had to get gauze so we could cover it up and tape around, and then, say like, listen, you're leaving against the medical advice. Let me go get the papers. Cool, we're good. But people go from like 0 to 100 just like that. Then wasn't my patient, it was another nurse's patient. And here's the thing. Once a man raises his voice at a coworker and it's a woman, I step in. I'm going to show up and I'm going to be there for security because you have no idea what's going on through these patients' minds. And psych patient, very combative. It took, how do I say this? You have to, there's abuse and then restraint. And it's a very thin line. But I do my best to try and like safely restrain a patient so that nobody gets hurt. Because again, you have no idea what these fucking patients are gonna do to you. So you're just trying to keep your distance and keep everybody safe. That was just bad. And that was the first time where I thought like, is this WWE or nursing? 10th shift off of orientation, I was in fast track and I saw something cool where this person came in with lower back pain. So we do CT and then we find out it's more serious than we think. And then I learned from the PA, if somebody comes in with lower back pain and there's a change in their bowel movements or a change in their urinary frequency, there's an issue, right? So what we found was his lower back was the reason why I was in pain is because of this thing called cauda equina, where there's a compression in the S1 through 5 and part of like L4, L5, where it's compressing against nerves, so then it causes pain, but then it also changes the frequency in bowel movements and urinating. And it was a problem. It was something where like this guy had to get an immediate MRI and then go up to surgery or go get a surgery consult, because the faster you treat it, the less risk for paralysis. Are you kidding me? I wouldn't have known this shit. So another thing to think about in the back of my mind when I'm doing assessments on patients who come with lower back pain, what else is going on? Then I also saw something cool. I put a picture up. We used a cyano kit because a patient came in from a house fire, and as you do this prophylactically, where you give the patient the cyano kit. I forgot what it's called, the medication, but the kit is called cyano kit. So if there's any cyanide exposure, cyanide poisoning in the patient's body, then you will see through, like, you have to also place a Foley. You'll see as the urine comes, it turns purple. Like, it kind of looks like hematuria, like dark red / purple, but it's purple, and you can kind of tell the difference. That was cool. Something I saw. Yeah, that's pretty much it. That's my first month off of orientation. Almost every shift is very tiring. Almost every shift makes you feel depleted and like you have nothing left to give. And in the same token, where it is the hardest thing that I've ever done, it is constant pressure, constant stress. It's also rewarding for the few times you get high praises or compliments from patients, when you're able to get a hard stick, when you're able to take care of people, right? Leave them better than when you found them. And a year ago, I was finishing my second to last semester, wondering what it would be like to finish nursing school, to start working in a hospital, in the ED specifically, and be a good nurse. And I'm still far from being a good nurse or the type of nurse that I would like to be, but I'm getting closer. And these certain milestones that I hit feel worth it. It feels rewarding. Like I'm in a good place and I'm happy. The type of nurse that I want to be will only come through time and through repetition and not giving up. So as long as I don't quit, I'll get to where I want to be. Now, the thing with that is I'm also going to be starting classes this summer, and I don't know what the destination is going to be, but for a few months now, I have been wanting to do more, wanting to know more. And instead of being the person who asks the questions or can't even answer some questions for the patient, I want to be the person who knows the answers, the person who can explain things thoroughly and can develop a plan of care from start to finish. So I'm starting to do prerequisites this summer for medical school, and I'm assuming it'll take me like 2 to 3 years to get it done. And in that time, if I still want to be a doctor at the end of it, then we're gonna take the MCAT, we're gonna apply to medical school, and then we'll go from there. And if I decide that I don't want to go to medical school route, then we'll just go for nurse practitioner. Cool. All right. I'll talk to you later. Bye.